What's up, everybody? Doc JJ here, and this is part 1 of Assessing Children, Infancy through Adolescence. Here is an outline of our lecture. We'll start with a brief discussion of history taking of pediatric patients. Then we will move on to newborn assessment. This will comprise your APGAR score and New Ballard scale. And lastly, a step-by-step order of infant assessment. Taking a pediatric history can be daunting if you're not accustomed to working with children. To look at pediatric history, children are resilient and tend to compensate when they are ill. However, they can decompensate and deteriorate rapidly. Identifying the age of a child is key in pediatric history. Let's take a look at the nomenclature. A newborn is age less than 28 days, and an infant is 1 month to 12 months. The age of a toddler ranges from 1 year to 3 years, a preschooler from 3 years to 6 years, school age 6 years to 12 years, and adolescent 12 years to 19 years. The child is generally accompanied by a parent or a caregiver in very young children who do not speak. The history is taken from the parent. It is important to be aware that the parents with a sick young child might be anxious. So when you take a history, be empathetic. And important notes to remember, in older children, the history can be directly taken from them. And some children might be shy and might be embarrassed to talk. It is important to be friendly, engage with the child early on. And do not ignore the child and talk to the parent all the time. Remember that the child is your patient. Also, parents can contribute with the history if ever a teenager cannot answer some questions. If possible, with all the teenagers maintaining autonomy without offending the parent can be tricky. Sometimes teenagers might feel uncomfortable to share personal information. If their parents are in the room, it might be necessary to invite the parents to leave to achieve privacy. The teenager might be more at ease to answer personal questions about sexual behavior, smoking, or alcohol. The pediatric history consists of specific elements not generally explored in a traditional medical history. It's important to remember to introduce yourself and gain permission to take history from the child and parent. If your patient is a newborn, you might want to congratulate the parents before you jump to the history. These are the components of history taking: general data, chief complaint, history of present illness, review systems, past personal history, which is comprised by gestational history, birth history, neonatal history, feeding history, developmental history, and past illness. Next is immunization history, family history, socioeconomic history, and environmental history. We will discuss all this one by one. The general data comprises the basic information of your patient, which includes the name, the age, which is the most important in the pediatric population because it can tell you the possible etiology of infections, the address, date of birth and place of birth, sex, ethnicity, and religion. Next is the chief complaint. This answers the question, why was the patient brought to the hospital? It can be a word or two words. Or if can't directly translate the chief complaint to English, you can quote what the patient or informant had uttered. Now we go to the history of present illness. This tells the story of your chief complaint. So it is important to get a chronological order of how the symptoms started, how it's developed, and where there's been change. Identify any aggravating factors or relieving factors. Ask whether there has been any episodes or similar illness. Ask whether the patient had taken any medications and note signs of relief, or had the patient previously consulted to other institutions. Ask associated or relevant symptoms connected to the chief complaint. If the patient is a newborn and the present problems are related to the prenatal and perinatal period, the maternal and birth history should be incorporated. With that said, from the general data, chief complaint, and history of present illness, we, as physicians, must be already formulating a differential diagnosis from the given information. Next is the review of systems, and it is meant to elaborate the data in systems that are not covered in your HPI. Remember that the symptoms written in your HPI must not be repeated in your review of systems. And it must be a detailed description of symptoms in a systematic approach. And this should be asked in a way understandable to the patient. Now we go to the past personal history, starting with the gestational history. It covers the maternal age, parity, duration of gestation, overall maternal health, nutrition, infections, and exposure to teratogens. Information from the gestational history can give a clue why our patient is suffering such disease or infection. Next is birth history. We can ask whether the patient is a term or post-term or preterm. And we can ask the manner of delivery, whether it is normal delivery or C-section. And who was the attendant during the delivery? If it was a midwife, nurse, or was the child born in a hospital or institution or in a lying in or in the traditional way. And the birth weight or the anthropometrics must be asked in the birth history, including your head circumference and length. Next is the neonatal history. We can ask for the Apgar score of the child during the delivery, or there any resuscitation done, or meaning as the child given oxygenation or positive pressure ventilation at birth. We can ask for any complications for bleeding or cyanosis experienced by the child. And are there any congenital abnormalities? These are seen in the physical exam. However, we can ask questions about the explanation of their doctor of how these congenital abnormalities happen. The gestational history, birth history, and neonatal history are mandatory in patients less than 2 years old, or if it is related to the illness in children beyond 2 years old. Next will be the feeding history. For infants, we can ask for the type of feeding that they're giving, whether it's exclusive breastfeeding, formula, or mix. And we can ask also when did they start complementary feeding. And as for childhood and the adolescence, we can ask for the appetite, whether they are a picky eater or what food they prefer in a specific period of the day. Ask for a diet diary, and we can compute for actual caloric intake and comparison with recommended energy and nutrient intakes. Next will be our developmental and behavioral history. So first, we need to identify the milestones. And these milestones are divided in 4 domains: your gross motor, fine motor, language, and social development. So this is a rundown of the milestones. So it is important to know the age of the patient. Though it may be difficult to memorize all this, I would recommend that you memorize at least 2 milestones on each domain so that in our ward works, you can ask questions regarding the development of our patient. So I will leave it all to you to read on this. Next, we'll be watching out for red flag signs. Besides being familiar with the different milestones, we need to ask for the threshold of each milestone. This can be an indicator to refer our patient to a specialist. For example, at the age of 18 months, your infant have an inability to walk independently. That needs to be a workout. And here you have your receptive language, your social, emotional, expressive language. And for school age children, it's not age specific, but we already have some situations showing that our patient is having a learning difficulty. Like the child might be a slow learner, has poor coordination, or being clumsy and being prone to accidents. And here are some more red flag signs for your school age children. Next, after identifying and watching out for red flags, we need to ask for the school performance. How are they faring well in school? Ask their grades, their favorite subjects, their least favorite subjects. And for adolescents, we need to ask for the heads. So heads stands for home, education, eating, activities, drugs and alcohol, suicide and depression, sexuality, and safety. And they added another S, which is the spirituality, and it is used as part of the intervention. Last component of your past personal history is your past illnesses. Ask for any contagious diseases or other medical illness, like whether they are taking any maintenance medications. Ask for past surgeries or allergies from any medications or food or any injuries inflicted to them. And as for pubertal females, you include the menstrual history, asking how many pads per day, when was the first menstruation, whether it's irregular or irregular. Okay. And next will be our immunization history. Ask for what type of vaccines uh, the child received and the number of doses and also the place of administration. Where did they get those vaccines? And whether there are any reported reactions or allergic reactions. So here is an updated chart of our vaccines here in the Philippines, showing you different kinds of vaccine given in a specific age and specific interval. Be familiar with this because it will help you in your history. Next will be the family history. We need to ask for the parents and whether the patient has any siblings or living with a relative. Ask for a list of familial illnesses or anomalies, or if there are any diseases and maintenance among the family. And if there is a genetic anomaly, we can use a genogram to demonstrate it with at least 3 generations in it. Next is your socio-economic history. So we are asking here for the living circumstances. So the place and nature of dwelling, the number of persons living in the house, and your economic circumstances, if the working members of the family, and the sources of funds. And lastly, we ask for the environmental history. The factors that can be detrimental to the child's health should be explored. And these are attributed to the exposure to any pollutants, garbage disposal, sanitation, and water source. Just some friendly reminders prior to physical examination. So show them it doesn't hurt by examining the parent first, and let the child examine you, and adjust the sequence of the exam based on the willingness and ability to cooperate, and offer gowns as needed. Now we go to our physical examination, starting off with our newborn assessment. So immediately after birth, we check for the APGAR score. So APGAR score is a scoring system ranging from 0 to 10 and is calculated by evaluating the newborn based on the 5 criteria. Each of these criteria can be allocated a score from 0 to 2, and then the sum of these criteria will give you the total of your APGAR score. So components of your APGAR score is your appearance, pulse, grimace, activity, and respiration. Typically, the APGAR score is calculated at 1 and 5 minutes after birth. If the score is low, and you usually repeat the score later in a 5-minute interval. A score of 7 and above is generally normal scores. Less than 7 are low and suggest distress of the newborn that requires some intervention. For example, suctioning or stimulation. Although APGAR scores are not used to determine morbidity or mortality, lower scores are typically thought to correlate with more severe outcomes. For example, scores of 3 that are persistent can indicate long-term sequelae such as neurologic damage. Ultimately, the purpose of APGAR score is to determine when the emergent interventions are necessary. The APGAR score is as follows. You'll take a look of the newborn's appearance. If they are blue or pale, give them 0 points. If blue extremities but pink body, you'll give them 1 point, and you will award 2 points if the body and extremities of the newborn are pink and without any cyanosis. For pulse, if it is absent, you score 0 points. If the pulse is less than 100 beats per minute, then you score 1 point. And in the ideal situation, the newborn's heart rate should be greater than 100 beats per minute, awarding 2 points. For grimace, you'll award 0 points if there are no response to stimulation or the baby is floppy. 1 point is awarded for grimace on suction or aggressive stimulation. And again, ideally, if the baby is crying on stimulation, you'll award them 2 points for activity. If the newborn is not moving, of course, award them 0 points. If there's some flexion in the arms and legs, you award them 1 point. If there's active flexion against resistance, you'll award them 2 points. And respirations, if they're absent, you award 0 points. For weak, irregular, or slow respirations, 1 point is awarded. And if the baby is strongly crying, you give them 2 points. These are just some classifications of newborns according to gestational age and birth weight. As you can see, preterm are less than 37 weeks, term for 37 to 42 weeks, and postterm for more than 42 weeks of gestation. And for birth weight, extremely low birth weight for less than 1,000 grams, very low birth weight for 1,500 grams, low birth weight for less than 2,500 grams, and normal birth weight is equal to or greater than 2,500 grams. Next, we have the new Ballard scale, which determines whether an infant is mature or premature. So there are two main components of the new Ballard scale. The first is the neuromuscular assessment, and second is a physical maturity assessment. So let's talk first about neuromuscular assessment. This has 6 different components. So the first component is posture. So our baby should be well flexed, but if going to kind of bent, more extended or like flaccid, then that is indicative of a premature infant. So well flexed means that they're mature, extended or flaccid means they are premature. The second component is something called a square window, which assesses the wrist. So if we take the hand, we should be able to bend their wrists all the way down until its arm. But with a mature infant, we should be able to do that. If that wrist can't go past 90 degrees, then that is indicative of a premature infant. Then the next component is something called arm recoil. So if we've got our baby here and take the arm and kind of pull it down, it should have kind of recoil back. If it doesn't recoil, then that is more indicative of prematurity. Then we have a popliteal angle. So if we take his leg and start going straight up, if we meet resistance, and if can extend his leg more than 90 degrees, that means we're dealing with a more mature infant. But if we can literally go all the way up the baby's face, then that's indicative of prematurity. Then we have something called the scarf sign. So with the scarf sign, I'm taking the baby's arm and moving it across the baby's chest. If we meet resistance, that is a normal finding in a mature infant. If we take the arm and wrap it around its neck and then it is in no resistance, it is indicative of prematurity. And lastly, we have something called heel to ear assessment. We bend the knee of the baby and we flex the knee and we bring the leg up. As we bend the knee, if we meet resistance and can't get past like 90 degrees, then that is indicative of maturity. So that would be a mature infant. If we take this leg and go all the way up to the ear, then that would be indicative of prematurity. Alright, now let's talk about the physical maturity test, which is like the second component of the new Ballard scale. So there are 6 different things that we are assessing in regards to physical maturity. The first thing we're looking at is skin texture. So if a baby is premature, their skin will be sticky and transparent. Then as they mature, it will thicken. And if the baby becomes post-mature, then the skin will become leathery and wrinkled. Then when we're talking about lanugo, for mature baby, they will have very little lanugo. Then with the premature baby, we will have abundant lanugo. And if we're talking about very premature babies, they will have no lanugo. Then next is plantar surface. Creases on the bottom of the baby's feet. If the baby is mature, we see creases across their sole of their foot. If the baby is premature, then it will be smooth. They will not be creases on the sole of the foot. And the next thing is the breast tissue. For a premature infant, the areola will not be perceptible. However, if we're dealing with a mature baby, we will have a full areola that is 5 to 10 millimeters in size. Then when it comes to the eye opening and ear cartilage, if the baby is really premature, those eyelids may be kind of fused shut. But for a mature baby, they should be able to open their eyes. With the pinna, if we take their ear cartilage and bend it forward for a mature baby, it will recoil back very quickly. But for a premature infant, if we bend it forward and it will stay there, then that's for your premature. And lastly, genitalia. So if we're talking about a little boy, if he is premature, his scrotum will be flat and smooth. For a mature baby boy, he will have a pendulous testicles and will be having a rugae present. Then for females, for a little baby girl, if she's premature, she will have a prominent clitoris and flat labia. And then when she becomes mature, then her labia majora will cover the labia minora as well as the clitoris. So those are the things to look at to gauge whether the baby is mature or premature. And after doing the neurologic and physical maturity, we will sum all the numbers we have taken and try to plot it in your maturity rating, and it will correspond to the number of weeks the infant is at. And I will put a title card here on your upper right to check for the actual demonstration of your new Ballard scale. Now we take up the numbers from your birth weight and in your gestational age, and we plot it in your intrauterine growth curves. As you can see, if the plotting is within the 10th and the 90th percentile, your baby is at its appropriate for gestational age. But if it is greater than the 90th percentile, your baby is large for its gestational age, while for below 10 percentile, it is small for gestational age. Large infants may experience difficulties during birth, and infant mothers with diabetes are often associated with large for gestational age. While for small for gestational age, although the etiology is still unknown, but they are trying to correlate it with maternal smoking. Now we go to the growth parameters that are used generally for newborns and infants. So first, we need to measure out the length of the baby. So first, we need to take the baby in a supine position on a measuring board or a measuring tray, as you can see in the picture, to get the proper measurement. Direct measurement of an infant using a tape measure is inaccurate unless you have an assistant that can hold the child still with hips and knees extended. Next is your weight. Weigh infants directly with an infant scale. Infants should be naked and only clothed with your diapers. And next is your head circumference. First, we have to do here is to place the measuring tape just above the eyebrows and ears. It is important to measure the child's circumference at the widest part of the head. Set the tape right above the ears so it's nearly touching them and line it to the forehead so it sits over the eyebrows. Second, pull the tape around the back of the head where the head slopes from the neck. With the measuring tape in place above the ears and brows, wrap it around the back of the head and be careful not to pull it too tightly. And lay the tape where the head slopes up from the neck. Make sure the tape lays flat against the back of the head where the slope is most pronounced. Overlap the tape slightly to get the most accurate measurement, and note the number. Measuring a baby's head circumference can be important to ensure that their brain is growing and developing as it should. And these anthropometric parameters are used to correlate whether the infant is growing according to its age. Now we go to our vital signs. First, we get the temperature. So it's more recommended to take the temperature in your auditory or rectal because they are more accurate than the oral and axillary. And next is your respiratory rate, which ranges from 30 to 60 breaths per minute. Then next is your pulse rate. You can take your pulse rate from your brachial or femoral pulse or directly from the heart, and it should range normally to from 100 to 160 beats per minute. As for blood pressure, there is a special tool that is used for a newborn or infant because we need an appropriate size for them. And the cup should be completely encircling and covering at least 2/3 of the upper arm. And it must be measured after 3 to 5 minutes of rest in a sitting position. And also, blood pressure is not totally indicated unless the child is severely ill. Next, we will assess for the skin. So what we're looking at here for the color of the skin, whether there are any birthmarks, any markings, take note of those, for it will be good when we try to assess for bruises in later parts of our well baby visits. And check for the turgor, pinch on the skin above the abdomen. And check for any rashes or any eruptions, for any scars, edema, and especially for jaundice. For checking of jaundice, To detect jaundice, apply pressure to the skin to press out the normal pink or brown color, and a yellowish blanching indicates jaundice as you see on your right. Next is the head. So what we're looking at here is the shape and the contour of the head, and for the sutures and the hair and the scalp. And we need to auscultate for any bruits. And we will palpate for the fontanelles. So palpating the fontanelles, we will note the anterior and posterior fontanelles. The anterior slightly depresses and pulsatile and best evaluated when an infant is held upright. And it closes by 9 to 18 months, while your posterior closes by 2 to 4 months. Next, we're going to check the eyes, and we absolutely are going to do a red light reflex. So red light reflex is useful because when you're looking at and you're seeing not only the red reflex, but also the possibility of sleep lenses, which can happen with a variety of infant diseases. So what to do a red light reflex, we need an ophthalmoscope, and we will set it to the 0 diopters and hold the ophthalmoscope and see through it by 10 inches away from the baby. And we must see in a normal red light reflex that both eyes have red to orange light colors. But if they are absent, as you can see in the picture, that may indicate of abnormality. It could indicate for retinoblastoma or any cataracts of, of the infant. So it is crucial to check those eyes. Also, look at the irises. If a coloboma is present, like you see here in the picture, it might indicate of a charge syndrome. Now, we will now take a look at the ears. We will note for the size, the shape, and location, and position of the ears. As you draw a line backward from the eye, it should intersect the top third of that ear. Also, you should note any abnormalities of the ear. As it posteriorly placed, is it rotated, or are there any pits? Or are there any tags, abnormalities of the ear that may be associated to syndromes, or maybe even just associated with renal abnormalities? So, low set ears might indicate for a Down syndrome. And we must check also for the ear canal patency using your otoscope, and we will note for the cone of light. An otoscopic examination for infants, pull the pinna of the ear downwards and posteriorly. Now we're going to check the nose. We will check for the patency of the nose, and if there are any nasal flaring that may indicate of a difficulty of breathing or hypoxia or shortness of breath and discharges from the nose. And we will note for the position of the septum, whether it's in midline or it's not in the midline. And we will note for any sinus tenderness if there are any infection. Now we're going to check the mouth. We're going to look for abnormalities of the lips, but we're also going to put our finger into the mouth and palpate the top of the mouth. If there's abnormalities in a cleft palate, you may note them, obviously, on the exam. But a palate on the inside may be high arc or may be abnormal as well as with a lack of patency on the inside. And that should be noted while we've got our finger there. And check for the baby's suck. It should be vigorous. Although it's part of the neurologic exam, I will already check the suck reflex by that time. And taking a tongue depressor, we will check for the throat and note for any inflamed tonsils on the baby. Next, we're going to look at the neck. The neck is important in infants because it can have abnormalities that are hard to see unless you really extend the neck. And look at it. Examples are the thyroglossal duct cyst, which has midline, or a brachial cleft cyst, which is lateral. So next, we will palpate the clavicles. It's common for clavicular fractures to happen in large babies or with a bad shoulder dystocia. And before we check for the lungs and the heart, we inspect for the deformities and retractions on the chest, palpate for masses, and determine chest lag. Check for symmetry and asymmetry by percussion, and determine the vocal primitus. Auscultation of breath sounds and adventist breath sounds. And next, remember that half of normal newborns will have a murmur in the first day of life. And here's a picture of a infant who is breathing with a chest in drawing, noting that this baby might be having a pneumonia. Next would be the abdomen. So the sequence of assessing the abdomen is same as for adults. Inspection, auscultation, percussion, and palpation. So inspection, what we're looking at is normally that the infant or a newborn's abdomen is protuberant. And we check for the umbilical cord. And what we're looking at for the umbilical cord is for two arteries and one vein. And check for any obvious hernias on the inguinal and umbilical area. Next will be auscultation. Auscultate for the vowel sounds. And next will be percussion. Percussion, obviously it will be tympanic. And palpation. So normally the liver is palpable in infants. And also spleen naturally palpable, but it can be palpated, and the kidneys can be best felt in deep inspiration with one hand placed posteriorly, with one hand anteriorly. Next is the genitalia, starting with the male genitalia. So check for any undescended testes. So majority assume normal position during the first 3 months of life. Also, we will note for any hydrocele, and we can examine that via translumination. And note for the urethral orifice where this the opening, whether it's above or below or is it in the normal. So hyposphagia if the opening is below, and episphagia if it is in the above. Next is the female genitalia. The labia minora and majora have a dull pink color in light-skinned infants and may be hyperpigmented in dark-skinned infants. During the first few weeks of life, there is often a milky white vaginal discharge that may be blood-tinged and decreases during the first year of life. Examine the different structures systematically, including the size of the clitoris, the color, and the size of the labia majora, and any rashes, bruises, or external lesions. Separate the labia majora at their midpoint with the thumb of each hand. Inspect the urethral orifice and the labia minora. Assess the hymen, which is in newborns and infants is thickened, a vascular structure with a central orifice covering the vaginal opening. You should note vaginal opening, although the hymen will be thickened and redundant, and note for any discharge. And for your anus and rectum, we will check for patency, bleeding, and masses, and possible parasites. And for your extremities, inspect for deformities, like your syndactyl and polydactyl. Palpate for pulses in your femoral and your brachial pulse. And assess for warmth of extremities. Examine the joints and range of motion. We'll note also the color of your extremities, noting for any acrocyanosis where the body is pink while the extremities are cyanotic. Next, we will check for the hips. Two maneuvers we can use is ortolani and Barlow test. So let's talk about ortolani first. So place the baby supine with the legs pointing toward you. Flex the legs to form right angles at the hips and knees, placing your index fingers over the great trochanter of each femur and your thumbs over the lesser trochanters. Abduct both hips simultaneously until the lateral aspect of each knee touches the examining table. While your Barlow test. You place your hands in the same position as for ortolani test, but pull the leg forward and adduct with posterior force. That is, press in the opposite direction with your thumbs moving down toward the table and outward. Feel for any movement of the head of the femur laterally. So main difference is that ortolani is abduction and Barlow is adduction. Next, we will check for the spine. We will note for any sacral dimples or tufts or any deformities like you're in your spina bifida. Lastly, we're going to do our neurologic exam. We've already done the sock reflex, but we're going to comment on it. During the neurologic exam, check for their overall tone. Babies should prefer to be all balled up. They don't want to have their extremities relaxed. If a child is relaxed and open, something is wrong. Neurologically, check the sock and check for rooting reflex, where you stroke their chin and they move towards it to suck. Check their grasp. These infants want to hold your finger. Holding your finger is a normal reflex in infants. And it is nice not to tell the mother that this is a reflex. Let her think her child wants to hold her finger. Also, check the Moro reflex, which should be done carefully. When you suddenly lower the head and the infant's arms will come out and spread. They may shake a little bit and then come back again. In infants, that is normal. What we're looking for is symmetry of the Moro reflex. If only one arm comes out, that could be a sign of nerve damage, perhaps from a brachial plexus nerve injury as a result of birth. Lastly, it is good to check the deep tendon reflex. The deep tendon reflexes are easy to appreciate in knees, for example of infants. And we can also check the heels for clonus. A little bit of clonus might be okay in early infancy. So thank you for watching. And if you're new to the channel, click the subscribe button and ring the bell for future videos.